Good morning all. Today I will be presenting admission rounds from HDF unit. We will be discussing a case of shock in a child with hyperdynamic PH. Demography, we have Master J, 9-month-old male, resident of Fatehabad, Haryana. The date of admission was 15th of October. Date of transfer to HDF unit was 16th and date of discharge was 29th. Chief complaints were cough for 2 days, difficulty in breathing for 2 days and fever for 1 day. Cough was dry type, gradual in onset, non-paroxysmal, associated with post-tussive vomitus. Respiratory distress in form of difficulty in breathing in form of increased rates, subcostal, intercostal retractions. Fever, which was undocumented, the child was noticed to be warm, but no medications were given. There is history of presence of suck-rest cycle since birth, forehead sweating since birth, no chills, rash, abnormal body movements or crying during micturition, no history of cyanosis or altered sensorium, no history of vomiting or loose stools. In the treatment history and past history, at 8 months of age, in view of poor weight gain, the child was evaluated outside and was advised echo, which revealed a large 20 mm ostium secundum ASD with severe tricuspid regurgitation. RA-RV were dilated. The child did a repeat echo at 8.5 months of age, which again showed a large ostium secundum ASD with left to right shunt with mild TR. The child was advised to follow up after 6 months as the current weight of child was less. Meanwhile, child got admitted in PGIMR from 20th of September to 27th for 7 days, where the child was treated as acyanotic congenital heart disease, ASD, with severe TR, with CCF pneumonia. The child was discharged on oral Lasix and NVAS at 0.2 mg per kg per day. Child received maximum HFNC support. Other history was unremarkable. Anthropometry-wise, weight, length and OFC were less than 2 z-scores, so final impression was underweight with stunting and microcephaly. On general physical examination, the child had moderate grade pallor with no cyanosis, icterus, clubbing, lymphadenopathy or edema. Systemic examination, cardiovascular system, there were no visible scars on the chest. S1, S2 was present, the S2 was loud. Respiratory-wise, air entry was bilaterally equal, but there were closed steps bilaterally. Abdomen-wise, liver soft, non-distended, liver was 2 cm under right costal margin, spleen was not palpable, CNS was fine. The echo did in PGIMR was suggestive of situs solitus, levocardia, atrioventricular and ventriculo-atrial concordance with normal pulmonary vascular drainage and systemic venous drainage, large 20 mm ostium secundum ASD with severe PH, hyperkinetic type, dilated RA and RV with good bioventricular flow. The child was advised CTVS opinion for early closure. In the triage, airways were open and stable, respiratory rate was grunting, efforts were increased, air entry was poor, on auscultation it had crackles, room air saturation was 36%, so child was intubated and put on IPPR on which the saturation was 98%. Circulatory parameters were normal, disability wise state to state variability was poor, the motor activity child looked lethargic. Exposure was fine. So physiologically categorized as respiratory failure type 1 with level 1 resuscitation. Course in ER. For respiration, initially the child was on IPPR, later it was shifted to PSA mode of ventilation with a PIP of 18 and PEEP of 6, FiO2 of 40 and rates of 40 per minute. For circulation, fluids were restricted to 70% N/2 5D. Suspecting pneumonia, the child was started on ceftriaxone. And for CCF, the child was started on Lasix 2 mg per kg per day. At 24 hours of hospital stay, the child was noticed to have BP less than 5th centile with poor peripheral pulses. So Lasix was stopped. 1 NS bolus was given and adrenaline infusion was started at 0.1 micrograms per kg per minute. Still, by 30 hours of hospital stay, as the BP was less than 5th centile, so adrenaline was hiked to 0.2 micrograms per kg per minute. By 36 hours of hospital stay, the child was shifted to HDF unit. This is the admission X-ray suggestive of bilateral pulmonary plethora and dilated RA. Course in HDF unit. For respiration, the child was continued in PSI mode of ventilation, maximum PIP of 18 with PEEP of 6 with FiO2 of 40% and rates of 40 per minute. X-ray in HDF again was suggestive of bilateral plethora with right-sided opacities. ET aspirant sent during the HDF stay was sterile and the child was extubated by day 10 of hospital stay. For shock, admission to HDF showed a pH of 7.26 with PCO2 of 48 with bicarb of 21 and lactate of 4. BP was less than 5th centile with poor peripheral pulses and cold peripheries. So adrenaline was hiked to 0.4 microgram per kg per minute. On this also, as the BP remained less than 5th centile, vasopressin was added at 0.0008 units per kg per minute. So by day 2 to 3 of hospital stay, the endpoints were achieved with BP more than 5th centile, central and peripheral pulses palpable, and lactate of 1.5. We were successfully tapered inotropes by day 4 of hospital stay. For the CCF, Lasix and which was withheld was restarted by day 6 of hospital stay along with Invas at 0.2 mg per kg per day. For pneumonia, child received meropenem for 7 days. Investigations were fairly normal except for anemia, for which child received 1 PRBC transfusion. So in the database, we have a 9-month-old male, a known case of ostium secundum ASD with chief complaints of cough, fever and difficulty in breathing. On examination, the child was anemic in respiratory failure with a loud S1 with liver 2 cm on the right costal margin. So initial diagnosis was ostium secundum ASD with severe PH with CCF pneumonia. Final diagnosis was ostium secundum ASD with severe PH with CCF pneumonia with shock. So regarding discussion of pulmonary arterial hypertension, it defined as mean pulmonary artery pressure more than 20 mm of Hg with pulmonary artery wedge pressure of less than 15 mm Hg with pulmonary vascular resistance more than 3 units per meter square. The incidence of pulmonary artery hypertension, the mean age of diagnosis is 7 to 10 years with gender prediction in idiopathic and familial cases, females more than more. For other types, females equals to males. The top causes are, first is congenital heart disease, followed by the chronic respiratory disorders, followed by the idiopathic or familial disorders. Viral infections can also be a trigger for pulmonary hypertension, especially human herpes virus 8. This is the causes of pulmonary hypertension. First most causes of pulmonary arterial hypertension, which can be idiopathic or heritable or due to intake of drugs. Second cause is due to left-sided heart lesions like systolic or diastolic dysfunction. Third can be primarily of lung diseases like chronic obstructive pulmonary disease, interstitial lung disease. Fourth can be due to chronic thromboembolic pulmonary hypertension. And fifth can be multifactorial. So how does shock develops in a pulmonary artery hypertension? Pulmonary vasoconstriction will lead to increase in the pulmonary vascular resistance, which will increase the right ventricular afterload. That will cause heterotropic adaptation and right ventricular dilatation. So dilatation of the right ventricle will increase the myocardial oxygen demand, which will cause ischemia as well as decreased coronary perfusion. Because of decreased flow to the lungs, there will be decreased venous return, and that will decrease the left ventricular preload and left ventricular output, leading to hypotension and hypoperfusion. Also, the bulging of the interventricular septum towards the left side will also decrease the cardiac output. Now, the role of vasopressin in PH. Vasopressin basically acts on the V1 receptors to cause vasoconstriction in the periphery, but it has been found that in patients with pulmonary hypertension or right ventricular dysfunction, it is preferred over other vasoconstrictors since it selectively supports the systemic vascular tone without increasing the pulmonary vascular resistance. This is a review article from the adult critical care which shows arginine vasopressin causing systemic vasoconstriction by V1 receptors as well as pulmonary vasodilation through nitric oxide dependent mechanisms by the V1 receptors. So this manifests clinically as reduction in the pulmonary vascular resistance and PVR-SVR ratio. This is one case study where 2 pediatric patients with refractory hypotension with pulmonary artery hypertension were successfully treated with arginine vasopressin. Comparing vasopressin versus non-adrenaline in pulmonary hypertension, first vasopressin versus non-epinephrine septic shock patients, a meta-analysis showed equal effects of both vasopressin and non-epinephrine, but vasopressin basically decreases the rate of RRT in patients with septic shock. Second is epinephrine versus vasopressin in pulmonary artery hypertension. It was observed that arginine vasopressin decreased the need of decreased mean pulmonary artery pressure as compared to non-epinephrine. So if we compare vasopressin, non-epinephrine and epinephrine, so vasopressin can be more easily preferred in hyperdynamic sepsis with hyperkinetic LV or with pulmonary hypertension. For epinephrine, we should go for hyperdynamic sepsis or vasoconstriction. So in our index case, the shock was managed with adrenaline and vasopressin. For CCF, Lasix and Invas were given, and for sepsis, meropenem was given. So these are take-home messages.